Okay, so now we're going to talk about heart failure. And again, heart failure is heart failure is a manifestation of or a complication of a lot of these diseases. We have heart failure for a reason. And it means the heart is unable to effectively pump blood, and that can be one side or the other, or it can be both. The causes, there may be structural abnormalities that cause increased blood volume and pressure within the heart. That's the most common cause in children. It can be because the muscle itself is not working, myocardial failure, and that can be from cardiomyopathy. That can be from dysrhythmias that just aren't getting the signal to the heart to pump effectively, from electrolyte disturbances, which also affects the signal, rhythm, or from ischemic damage. A part of the heart has been damaged by a heart attack and doesn't work effectively. Another cause is excessive demand on normal heart muscle. Sepsis, severe anemia, and chronic hypertension cause the heart to have to work harder. And so we can have heart failure because the heart cannot keep up with the demand. Chronic hypertension is the most common cause of heart failure in adults. We talk about left side versus right side heart failure. Let's go back to our heart diagram. Okay, and this diagram is focused on the valves. We have the entire heart here. We have the right side of the heart, right atrium, right ventricle, goes to the pulmonary arteries, goes through the lungs, picks up oxygen, come back through the pulmonary veins to the left atrium, left ventricle, through the aorta, out to the rest of the body. Okay, so if we have right side heart failure, that means the right side of the heart cannot pump effectively. So we're not getting enough blood to the lungs. So what is that going to look like? We don't get enough blood to the lungs. What does that look like? Think about your patient. Think about that child you're taking care of. And if the right side of their heart is failing, what are they going to look like? Well, if they can't get blood through the lungs effectively, they're going to be cyanotic, or more likely to be cyanotic. So they're going to have hypoxemia. But if the blood can't go forward, it backs up. And remember, when it backs up and these veins get really distended out through the whole body because they can't get blood back into the right atrium because it's already full, because it won't go forward to the lungs. Okay, when that blood backs up, the veins distend and they get leaky, so we have peripheral edema. So right side heart failure, hypoxemia, peripheral edema. Okay, blue, swollen. Okay, left side heart failure, we have less blood going into systemic circulation. So they may be pale if they can't get as much to systemic circulation. But where does it back up? This is where we see the symptoms first, because pulmonary circulation is a lot smaller. Backs up into pulmonary circulation, those vessels, those veins get distended and leaky, and all that water, all that fluid leaking out of them sits in the lungs, so they have pulmonary edema. Okay, they also have elevated pulmonary pressure. Now, when one side fails, that causes the other side to have to work harder, because now we've got pulmonary edema, the blood keeps backing up. Now we end up with the right side having to work harder, and it can develop failure eventually that leads to failure of both sides. What you need to understand is that happens more quickly in children. So whichever side it starts on, they end up with both sides not working well. Okay, what does it look like? Well, the symptoms are going to be based on either where the blood's not going or where the fluid is going, because the blood's backing up in those vessels. So impaired myocardial function, so they're going to get tachycardic. They may have inappropriate sweating. They may have decreased urinary output because they're not pumping blood forward to perfuse the kidneys. They feel fatigued and weak because they're not perfusing their brains and their bodies, their muscles. They feel restless because they're not perfusing their tissues. short of breath, pale, cool extremities because they're not perfusing those tissues well, weak peripheral pulses, decreased blood pressure. They may have a gallop rhythm. When you listen to the heart, you may hear a gallop and the heart starts to enlarge. Okay, that's because of blood not going forward to perfuse the tissues. Now, pulmonary venous congestion, this is the blood that's not going forward, backing up into pulmonary circulation and leaking. So they're tachypneic because they're running out of room to exchange gases because they're full of fluid. They're dyspneic, they're short of breath. You've seen people in CHF by now in clinical. They may have retractions where the tissue is kind of sucking in, where they're trying to reuse these accessory muscles to get more air in because they're full of water. Nasal flaring, exercise intolerance, any activity at all just makes them exhausted and short of breath. Orthopnea, they can't breathe laying down, they have to sit up. Paroxysmal nocturnal dyspnea, when they lay down and go to sleep, they wake up suddenly, sit up, gasping because they're drowning in their sleep. They may have a cough and be hoarse. They may be cyanotic. Now, if we're not perfusing the lungs, we're cyanotic because we're not getting oxygen at all. But if we're perfusing the lungs, but half of them are full of water, we can get cyanotic because we're not exchanging gases because the lungs have water. So they may be cyanotic, they may have wheezing, grunting. You might hear crackles, but listen for diminished breath sounds and wheezing for littles. Systemic venous congestion. So all this is right side failure. We can't get blood to the lungs, so it backs up. They may have weight gain. Hepatomegaly, the liver may be enlarged because it's got too much fluid in it. Peripheral edema, look around their eyes, periorbital edema. Ascites is really heavy edema or a lot of edema right in the abdomen. The jugular vein may be distended. So diagnosis of CHF is based on symptoms. A chest x-ray may show cardiomegaly and may show pulmonary congestion. EKG changes may be seen. An echocardiogram might be done to try to figure out why they're in heart failure. A BNAP is used to determine the severity of heart failure in adults. It's being evaluated for use in children, but we don't really have standardized guidelines for interpreting that yet. Medical treatment, the first line medical treatment is determining and correcting the cause. Infants of CHF it's most often due to congenital heart defects, and they need to be stabilized and prepped for surgery. So the goal is to keep them stable or get them as stable as possible until they're strong enough for surgery. Also, to manage that heart failure, they want to improve cardiac function. So they want to increase cardiac contractility, so make the heart be able to contract stronger and decrease afterload. Okay, cardiac glycosides increase contractility. They're inotropic. Do you remember talking about heart meds? We talk about inotropic, dromotropic, chronotropic. Okay, inotropic has to do with the strength of the contractions, and if something is a positive inotrope, it makes the heart contract harder. Okay, chronotropic has to do with the rate. So if it's a positive on a chronotrope, it makes it contract faster. Cardiac glycosides are inotropic, and they are a negative chronotrope. They're negatively chronotropic, meaning they slow down the heart. Digoxin is the one most often used in kids. It's dosed in micrograms rather than milligrams. They need to be monitored by EKG when they're starting on digoxin. It slows the heart rate and makes it stronger. Digoxin has a very narrow therapeutic range. It is critical to measure levels. If that child is hypokalemic, their potassium is low, it's going to increase their digoxin level. Okay. Digoxin is highly protein bound. So anything that decreases protein binding sites increases dig level, so they can become toxic. Signs of dig toxicity: poor appetite, anorexia, diarrhea, nausea, vomiting, bradycardia, their heart rate is slow, PVCs, premature ventricular contractions, other cardiac dysrhythmias, headaches, malaise is the feel bads, blurred vision. Now, if they're old enough to be able to tell us about vision, they may see white, green, or yellow halos, or they may have blurry vision, confusion, and delirium. Severe toxicity, we give digoxin immune fab. It binds to digoxin so it can be excreted. Okay. Another class of meds that are used in heart failure are ACE inhibitors. These are usually end in pril. They decrease afterload by relaxing the vessels and decrease fluid retention. Okay, so they decrease afterload. What does that mean? Okay, there's a diagram in your notes about preload and afterload. Let's go look at that. Okay, so let's look at this preload and afterload. Preload is the volume of blood in the ventricles at the end of diastole. Okay, and we're going to talk about this again in a minute. So preload is how much is going in. Afterload, so it has to do with volume. Afterload is the resistance that the ventricle has to overcome to circulate the blood. So afterload, see the clamp, is about pressure. Okay. All right. So ACE inhibitors decrease afterload. They by relaxing the blood vessels, so they're vasodilators. They also decrease fluid retention, and remember, too much fluid in that vessel increases afterload as well. So they decrease fluid retention, relax the vessels. ACE inhibitors can increase potassium levels, so be aware of that. Beta blockers block the actions of epinephrine and norepinephrine. They decrease afterload by relaxing the vessels, but they also slow the heart rate. Beta blockers should not be abruptly discontinued, and they shouldn't be given to a patient who is bradycardic or has a second or third degree AV block. Beta blockers are selective, can be selective versus non-selective, and what that means is whether they affect things besides the heart muscle itself. If you look in your pharmacology book, okay, go to chapter, let me find it, 15, adrenergic agonist and antagonist. In chapter 15, on page 175 is a diagram of all the systems and how they're affected by the sympathetic nervous system. Okay. On page 174, it breaks it down by which receptors: alpha 1, alpha 2, beta 1, beta 2 receptors. Beta blockers block stimulation of those beta receptors. If they're non-selective, they block all of them, beta 1 and beta 2. So that's going to affect the heart, kidneys, GI tract, lungs, uterus, liver. Okay, and they're blocking. So whatever this book says the sympathetic nervous system does, beta blockers are blocking that. A selective beta blocker focuses on beta 1 receptors, so it affects the heart and kidneys with less effect on the other systems. Okay, so that can decrease the side effects. I want you to look at those. The one side effect that I want you to consider, and the reason that we need to, something we need to assess before we give beta blockers. One of the effects of beta 2 adrenergic receptors is to dilate the bronchioles, open up the lungs to allow for more air to get in. Okay. If we block beta 2, someone with asthma who is dependent on adrenaline or epinephrine to keep their airways open may have bronchospasm. Okay, so patients with asthma, we need to be very, very cautious with non-selective beta blockers. Sometimes they will use cardiac resynchronization using a pacemaker to keep the ventricles contracting in sync in heart failure to improve cardiac output. Major issue, there are two major issues with heart failure: cardiac output not going forward and backup and retaining fluid. So the other thing that needs to be done is remove excess fluid and sodium to decrease preload. Loop diuretics are the most common, and Lasix is the most commonly used in children. Lasix is the trade name. You need to know furosemide. NCLEX test on generic names. So furosemide blocks the reabsorption of sodium in water. So it allows sodium in water to be eliminated in the urine. It wastes potassium. Okay, so you also eliminate potassium. So people on loop diuretics, we now have digoxin, that if our potassium level is too low, they're going to get toxic on their digoxin. We potentially have ACE inhibitors that increase potassium levels. Now we got a loop diuretic that wastes potassium. So what do you think needs to be monitored in this kid with CHF? We need to be watching their potassium levels. Okay. Thiazide diuretics may be used. They decrease sodium, water, potassium chloride, and bicarbonate reabsorption. So they're also potassium wasting. So they're losing all those electrolytes and water. Spironolactone blocks aldosterone and allows for the excretion of sodium and water and potassium retention. So it is a potassium sparing diuretic. Okay. Sometimes fluid restriction may be needed if diuretics can't get enough of the fluid off, because if they're fluid overloaded, that makes it even harder for that heart muscle to contract, because now it's all distended. So sometimes fluid restriction is needed. Rarely is it needed for infants because heart failure makes feeding difficult. Sometimes sodium restriction, we are usually stricter about that with adults, but kids, we want to be careful not to be too restrictive with that sodium restriction. So we're looking at the goals of care: determine and correct the cause, improve cardiac function by increasing heart contractility and decreasing afterload, remove excess fluid, decrease cardiac demand. That means we want them to not have their heart not to have to work hard. They need a neutral thermal environment, especially for infants. We need to quickly treat infections, reduce the effort of breathing. So semi-Fowler's is the easiest usually. Sedate or comfort fussy kids because they use up a lot of energy with that. Rest and decrease stimuli. So we want to really try to keep these kids calm and not ask too much of them while they're in severe failure. Improve oxygenation and reduce oxygen demand. So they need supplemental oxygen, and we've already talked about reducing oxygen demand. Surgical management for end-stage CHF, transplant is an option. Ventricular assist devices can extend their life or be a bridge to transplant. Nursing management. So we talked about the medical management because we need to understand what the provider's goals are. What can we do to help meet those goals? Administer digoxin. So when we're administering digoxin, dosage calculation is absolutely critical. This is something you're going to check with another nurse. We monitor carefully for toxicity. You always assess an apical pulse for a full minute. They may have a pulse deficit, which means they have a lower pulse in the periphery than they do apically. Pulse limits for administration are higher than for adults. So there should be some specification. For adults, you hold dig if their pulse is less than 60, right? That's too low for a kid. We want them higher than 60. So that should be specified in the order. And if it's not, you need to ask for a specific one, and the dig needs to be held and discussed with the practitioner if their pulse is significantly lower than previous pulses. And then we need to do lots of teaching for that family to be able to administer that safely and monitor at home. To help reduce afterload, again, ACE inhibitors, we monitor blood pressure before and after, monitor for symptoms of hypotension, monitor electrolytes and renal function. To decrease cardiac demand, we want to promote rest and conservation of energy, cluster care to allow for them to have uninterrupted sleep, encourage parents to be present, and sometimes we have to advocate for parents to be allowed to be present. Kids tend to sleep better and have less distress when they are when their parents are present. Baths and linen changes need to be done only when needed. We need to feed at the first sign of hunger and plan their feedings around their natural sleep-wake cycle. They need smaller, more frequent feedings. Sometimes 2 feedings are necessary to decrease that work. Minimize stress. Older kids need to know what will be happening because they get stressed when they don't know. They can imagine stuff that's a lot worse. So let them know what's going to be happening and decrease their stress. Temperature management and preventing skin breakdown, because when they're swollen, they're more likely to have breakdown. Reducing respiratory distress, we want to position them to allow for maximum respiratory or chest expansion. They need to be elevated. Safety restraints, like in a car seat, need to be applied loosely. If they're not able to pass the car seat test, they need to a specialized car bed. Supplemental oxygen and prevention and treatment, a prompt treatment of respiratory infections. Nutrition is an issue because they don't have the energy to eat. So we need to balance the metabolic demand of feeding, how much work is it for them to eat, with the increased need for calories. They need more calories because they're using more. So we want to feed them when they're well rested. We want to do small, frequent feedings, usually around a 3-hour schedule. They may use a soft preemie nipple or have an enlarged opening. They should be fed semi-upright with frequent rest, and they may need encouragement to continue sucking. They get tired. Feeding should not go on for more than about 30 minutes. We've got to let them get some rest. If they can't get adequate nutrition by oral feedings, they need to be fed, they need gabbage feeding, 2 feedings. The calorie density of formula may be increased, so they may get a formula that doesn't have more solutes, it has more calories, or they may use fortifiers for breast milk. We want to promote fluid excretion, so we may be giving diuretics. Again, remember dosage calculations. If we're doing diuretics, isonos and daily weights. Monitor for dehydration and electrolyte imbalances, because all of those different diuretics do different things to the electrolytes. If a child is not in diapers, it's best to give their diuretic doses earlier in the day so that they're more able to sleep through the night without bedwetting. Fluid restriction is rarely needed in infants, but if a child or young adults on fluid restriction, we need to plan their intake for 24 hours based on their typical needs through the day. So we want to not use up all of their fluid restriction before noon and then be thirsty until midnight. Older kids can help record. Younger kids, actually this helps for older kids and adults too. A small cup makes the amount seem larger. And we need to teach about salt restriction as appropriate to families and older children. Remember that salt restrictions are not as strict for kids. Support for their child and family. There's a lot of fear and anxiety. We want to help them prepare for whatever procedures or changes may be coming next. Frequent communication and help to reassure parents that everything possible is being done. We want to teach them about the needed home care, and that teaching needs to be very, very specific with lots of time for practice and return demonstration. And we may be helping parents set up end-of-life care. Okay, the last section is going to be about shock.